community, which are all of the sites that we're working with across the programmes from the Sustainable Improvement team. Then hand over to Bill and to Steve, who are going to talk us through their presentation around developing robust capitated budgets. And I've already heard this presentation, and I think it's fabulous around how they've used whole population data and lots of intelligence that we all have available to us to really focus on how they're going to move their programme forward and develop and improve services for people with long-term conditions. So hopefully you'll find it as interesting and exciting as I did. I'd now like to welcome Southend CCG, who are partners we've been working with for the last 4 years of the LTC Year of Care Commissioning Programme, and have been developing and understanding their priorities and their issues, so that they can share with you how to use intelligence and data, how to move things forward across health and care economies, and how to collaboratively develop things in a positive way. So on that point, I'd like to welcome Steve and Bill to talk us through their presentation.
Okay, hello everyone. My name's Bill Wood. I'm one of the Business Intelligence co-leads within the Ethics pod of NEL CSU. I've been working with Steve Downing from Southend CCG's finance lead for a couple of years now on the Year of Care programme. And part of that, my work has been involved around developing a sort of capitated budget for patients with long-term conditions. So aiming to build a tariff model that reimburses providers for providing a whole year of care for patients with long-term conditions. The aim is that that tariff can then facilitate efficiencies to be developed through improved care of those patients with long-term conditions, to identify those that are being well managed and not so well managed, by looking at the cost differential between sort of the average and the lower and higher end of those types of patients, and to move away from sort of a cost per case basis of tariff, where we pay for a single spell of care rather than a whole year of care, that can then enable that sort of efficiency improvement to occur with those patients. So what we looked to do initially was to bring together data into a single place from across a range of sources. So some of that would be around SUS for acute care, which is obviously a big portion of our activity. We also looked to bring data in from 2 of our primary care systems, so EMIS and System 1, which covered primary care costs, so mainly prescribing costs and community costs. And also, I can't remember the name of the system, unfortunately, and I didn't find it out in the interim, but we also brought in information from the social care system that the local borough council use. So that would then bring in the social care costs as well into that information. Areas we don't currently include are continuing healthcare, mental health, and some of the acute activity that is non-SUS based. So that typically is the direct access radiology, pathology, and sort of high-cost drugs areas, which we would like to still get in, but at the moment they're not actually in the model. One of the things we've has a hurdle, but we have challenged, is some of the IG guidance around getting data into a single place and making sure that we have consent for that data, or appropriate exceptions around using the Section 251 agreements to get that data into a single place. Our initial analysis and the initial collation of this data actually occurred prior to the Section 251 ending a couple of years back now. So in the interim, we haven't been able to update this data, but we will be looking to do that soon. So we collated data from those 3 systems that I mentioned earlier across 2 years of care. Those years were 2011-12 and 12-13. Through that, we were able to triangulate each patient and flag them with a long-term condition, or the list of long-term conditions that they suffered based on the primary care data registers, and also build in a flag to tell us how many conditions were identified for that one patient. Now, the reasons we did that was that we had a premise that the cost of a patient could be modelled based on the number of long-term conditions a patient has, but also the specific long-term conditions that that patient suffers. The 14 conditions that we identified in our data set are listed there below. I won't run through them all, but we did look at each of those conditions separately. The way we did that is we basically split all the patients into separate divisions or separate cycles of patients based on the number of long-term conditions and identifying a specific long-term condition within that bracket. So, for example, one of the divisions looks at patients who have 3 long-term conditions, one of which is at least coronary artery disease. And then for that group of patients, we looked to calculate their mean cost, median cost, the sort of variation in those costs, the standard deviation. And we also looked at what the sort of lower and higher extremes, so the top and bottom 10th percentile was for that bracket of patients, and then recalculated the averages excluding those extreme values, just to avoid the extreme outliers having a big effect on averages, essentially. Once we've gone through every single cycle of patients, so all number of long-term conditions and every single unique condition within that bracket, we then collated that information to a single table and then assessed what the mean and median costs were for each of those patients for 1 year. So we did it across 2 years and essentially divided it in half to get an average year, and removed the top and bottom 10th percentiles, as I said earlier, to avoid those extenuating high and low values. We then kept both the mean and median cost and had a little bit of a debate about which one of those could be used as a proxy tariff. There's benefits to using either the mean or the median. The mean is obviously slightly easier to understand. It's mathematically modelled, and it includes all known values in the calculation, so it's quite good for large samples. The mean will, again, help you ignore really extraneous values because it just looks at the central value for a range of values. So it is quite good at smaller samples where that effect can have quite a big influence on your values. We also reference to the National Tariff Payment System for 1516, which does indicate that they use a mean value as the basis for their tariff calculations based on the reference cost data that acute providers provide annually. So in the end, we did settle for using the mean based on the fact it has been used in the past, but obviously we can review that and look at that again. We also noticed that when we modelled the table across a particular condition, so for example, looking at coronary artery diseases, or in this case, the chart there shows asthmatic patients, we noticed that as you increase the number of long-term conditions that patient had, it tended to peak at actually 5 or 6 long-term conditions rather than the 7th that we maxed out the values at. We suspect the reasons for this is down to the smaller sample size when you get down to 7 or more long-term condition patients, which means that the lower samples can have a bigger impact on the values there. We also took into account the fact that once you get to higher values, again, that smaller sample size means that you're going to have a very large confidence interval in the value that you calculate. So you can see in the example below there for COPD, the confidence ranges are quite small, between 1 and 5 long-term conditions along the bottom of the axis. But once you get to 6 or 7, that confidence interval range is quite notably higher. So you can see for 6 long-term condition patients, you're looking at between 6,000 and 12,000 almost as the sort of annual average cost for a patient with COPD and 6 long-term conditions. So what we did is we took all those values for each of the specific conditions and plotted them by the number of long-term conditions of that patient and tried to look for any sort of trends or patterns that we could see across that data. The majority of those divisions of patients appeared to fit some sort of logarithmic trend, but though some were also still quite linear or even exponential in one case, which I'll go through shortly. But what we did is we then built a tariff model based on the trend that we could observe in the actual costs, excluding any visible outliers that we could see in the data, to build a trend for that cohort of patients. So in the next series of charts, I'll just go through some of those models. So you can see for patients who suffer from alcoholism, you can see that along the bottom of the x-axis, we have the number of long-term conditions the patient has, and at least one of those will be alcoholism. And you can see the black line shows you the trend line, the logarithmic trend line that we've associated to that activity. Now, one common thing that I'll raise at the end is that with a logarithmic trend, it tends to understate the value of patients with one long-term condition due to the way that a logarithmic trend is calculated. It will understate that initial one long-term condition patient. We did in this case exclude patients with 7 or more long-term conditions, which you can see as the hashed bar at the end there, simply because the value is clearly a lot lower than you might expect following the trend, but also there was a low sample size, so there were less than 10 patients involved in that group. Asthma, again, we modelled a linear trend. There was an argument here for, a logarithmic trend. There wasn't a discussion about having that as a linear trend, but for the moment we've modelled that as a logarithmic trend still, mainly because we didn't want to exclude the points 4 and 6 there, so 4 long-term conditions and 6 long-term conditions. But you can see it still almost fits that logarithmic trend where you see an initial steep increase in cost as you move up the number of long-term conditions, which plateaus when you get to 6 or more, or begins to plateau. Cancer fit the model quite well, so you can see initially, again, a lower at the beginning of the chart and tails off at the end, so there's a lower cost differential as you move to 5, 6 and 7 long-term conditions. CKD, we saw a massive outline, patients with 6 or more, 6 long-term conditions rather, so we did exclude that one from the chart there. Chronic lung disease across the board had quite a low sample size, so this one actually showed quite an erratic cost values across the number of long-term conditions those patients suffered. So this one doesn't really fit any particular model quite well unless you want to go for an up-down model all the way through, which doesn't sort of build into common sense. So that one's probably one that we can still look into a bit further. COPD, again, was one that was difficult to model directly, but it did slightly fit a logarithmic trend. You can see it dips slightly between 2 and 4 long-term conditions away from that trend, but it does fit the model when you get to 5 or 7 long-term conditions. And again, we had to exclude patients with 6 long-term conditions, one of which was COPD, because of the low sample size. Because that one was actually visually an outlier, rather. Next one was chronic heart failure. Again, that one fits the model quite well, and we excluded 1 point there. So the patients with 4 long-term conditions, one of which was chronic heart failure from the list there. Chronic coronary artery disease, again, fit the model quite well, and we didn't have to exclude any points for that one. Dementia was an interesting one in that it clearly didn't fit a logarithmic trend, and instead is the single exception that fits an exponential curve, indicating that the more long-term conditions that cohort of patients suffers, the more increase in costs that you see. So with each long-term condition, the cost differential actually increases with each step. So that was quite an interesting change from the other cohort of patients. We did have to exclude patients with 2 long-term conditions from that line model, simply because it was a slight visual outlier, so it was above 1 and 3 long-term conditions, which didn't fit the curve. Again, depression fit a logarithmic curve, and again we've excluded 0.6 and 7 there due to being small samples and visual outliers. And diabetes was very similar as well there. I won't bore you with them all. We'll then move on to the full picture. So what we did at the end is we merged all those logarithmic and exponential models into a single chart. And this helps to explain the sort of model that we believe may work for this sort of capitated budget approach, whereby each patient is tariffed based on the number of long-term conditions that they suffer and the particular presence of a long-term condition. So the example I've used in this chart is a patient with 2 long-term conditions, one of which is congestive heart failure, would have an annual tariff of just under £4,000, 3,990. If that patient then develops a 3rd long-term condition, but it's not chronic kidney disease, they would still stay on that blue line, and they would be slightly higher, so approaching sort of £4,500. If that 3rd condition was in fact chronic kidney disease, they would move up to a different curve line. So they would then go to chronic kidney disease and cost £4,600 a year. So it's the presence of different conditions which affects which curve that they fit on, and it's the highest curve essentially that they would then be placed onto. So it's almost repeating what I've said here. So we can base the tariff for the patient on the number of long-term conditions that they have and the particular presence of a long-term condition within that collection. So I've used an example there of patients with depression, asthma and dementia. And the highest value long-term condition there would be dementia, costing just over £3,000. If they then develop a fourth long-term condition of diabetes, the diabetes is actually a lower ranked condition in the curve than dementia is. So dementia would remain the highest valued long-term condition, and they would still be on the dementia curve line, but they would go up a band to 4 long-term conditions and cost slightly more at £3,800. This results in 77 unique tariff levels. When you compare that to HRG4, that's still a lot less, so it's not too high. And what we then look to do is compare our results from the model back to the data that we originally had, just to see what the cost difference was between what we started with, so the original sort of episodic care payment basis. And this table on the right here shows you the sort of cost comparison that we found. I've split the data between patients who we identified as being in the bottom 10th percentile and the top 10th percentile. So remember when we excluded those high and low values, I've also sort of separated them out in this cost comparison just to see and just to show that we would expect those patients to be heavily overfunded and underfunded respectively because we've excluded them from our averages. What we would like to see is that the central 80% is as well funded as we would expect. What we find is that it's actually underfunded by just under £4 million, just looking at 2012 here. We expect it to overfund the bottom 10th percentile, and we expect it to underfund the top 10th percentile because we've excluded them for those reasons. But it's the middle central 80 percentile that we would like to improve the model for. As I stated earlier, one of the reasons we think that might be the case is because of the use of the logarithmic trend line, which would always end up understating that first group of patients in the one long-term condition bracket, which would be a higher proportion of patients anyway. So that's one area we're going to continue to look into to see if we can adapt the curve line to take that into account. And we've got a few more ideas about what we'd like to do going forward. So obviously one of the things we'd like to do is update the data, bring it up to date 2014-15 or later if we can do. We'd also like to, and we discussed this in a previous version of this presentation, remove patients who died within 12 months of the end of the dataset period. One of the issues around that is using the public health mortality file, which is locked down to public health usage at the moment. So we're trying to work out a way that we can bring that dataset into our model and remove those patients because we are aware they would have obviously a higher cost within 12 months of death, and exclude those patients from the list because of that. As I said, we'd like to review the use of logarithmic trend lining, which would account for that underfunding of patients with one long-term condition, and also explore if there's any potential to add in further patient factors, so age, gender, and various other patient factors to see if we can diversify the model a bit more and make it a bit more specific to different patients. And finally, we'd like to model this approach in other areas just to see if the results that we see in Southend are comparable with other areas, and also to bring avoid the smaller sample size issue. So if we had more data from a larger patch, we might be able to bring in those areas that were previously excluded as being smaller samples and improve the quality of the model that way. I'm just going to pass over to Steve now, who hopefully can talk through some of the issues and barriers that we had.
Yeah, the issues and barriers which we've come across, and we've still got one or two of them, is obviously around the data sharing agreements. Obviously, don't want to mention it too much, but we actually went down the 251 route, and even though we've actually got that now, there are still quite a lot of restrictions around what we can actually use. But since that time, there's lots of new models which we can actually, or new ways of actually collecting that data and actually sharing that data. So we're going down a slightly different route with our Descro at the moment to see if we can actually expand the amount of data we can use, which seems to be a positive route. We're about to share our latest data with our council, and the other one, which is around continuing healthcare, which we'd like to get in because that's a significant cost to us. But one of the things I would say is don't ever underestimate the logistics in getting sign up to all of this, because even though you think you've got sign up, you haven't, and there is a lot of work which needs to be done. So don't underestimate how much time and effort it takes to actually get all these signed up. Currently, we've got out of our 35 practices, we've got 21 who are actually signed up to actually share their data. The others, we can't actually use their primary care data because they've not signed up to it. So, as I say, don't underestimate what you need to do around that. There's still one or two issues around NHS numbers and actually coding issues. That's more around the likes of prescribing and also around our continuing healthcare, because sometimes they're not actually using the NHS number, but we're sorting that one out. But in the majority, if for this area, we're actually quite good, apart from the ambulance trusts, which don't always use the NHS number. And the other one is around organisational sign-up. You need to put a lot of time and effort into actually making sure that all the organisations you want to get information from are actually happy to actually sign up to it, and they actually are or do understand what you're using it for. And that's not just your acute trust, because most of that you'll get anyway, but it's your mental health trust, your community trust, the actual council themselves, and obviously the biggest one is obviously with the practices, which is significant because you need to get every single one signed up to that. So that's where we're at. Other considerations and lessons learnt. One of the things we need to do is that to make sure that we've done a lot of work around the tariffs. And one thing we did find is that we had a number of vehicles which we were going to use to actually help develop schemes which we want to do in the community, like the one which is around care homes and nursing homes, which Bev mentioned earlier. We're obviously trying to set up, and it will go into effect from April, actually having a dedicated GP practice who actually will go in and actually pick up all the nursing homes and all the patients within there. And we're hoping to actually utilise this tariff to actually be able to do that, because the majority, a large proportion of the patients who are actually in care homes have got long-term conditions. So this, we think, is a good way of actually promoting that and actually getting people to actually look after their patients properly. And it's also given us, I mean, I know we haven't really sort of gone live on this, but one of the things it has given us is a good insight into actually how care pathways work and how you can actually change the way you look at how you commission services. Because one of the things it does do is actually start breaking down the barriers between us in terms of the NHS and in terms of care. And we are working a lot closer with our council now, and this has actually had a big benefit to do that. So it's not just about how you actually do the commissioning, but it's about actually how you look into what you really do need to commission. Because in the future we're looking to try and see if we can actually have a predictive model so we can actually identify these long-term condition patients early, so we can get interventions in there before they go down the current routes which they tend to go down. And I think that finishes us, so hopefully everybody found that useful, and thank you very much.
Brilliant, thank you. I was just as interesting the second time round, so thank you very much indeed, both of you. That's a lot of information also to take in, but I think you've you know, kind of built on some of the work over the last 3 or 4 years and really got to a point where you can do something really helpful and useful for people with long-term conditions, so fabulous. And I'll just turn around to our audience now and say, you've got an opportunity now to ask questions. I can already see some of you are putting questions into the chat box, so we will come and work our way through them. Please put your hand up, also if you've got a question, and where we can, we're going to make sure you can ask them in real time rather than myself and Bill and Steve having a conversation around you. So please do ask any questions. Now is a good opportunity to pick their brains. We will be sending the slides and the WebEx out after the session, so you'll be able to go back to some of the things that might be of particular interest to you. And also do let us know what are the priority areas out of this so we can help to build your knowledge as well. So on that point, I think we'll go to Kate first from one of our other early implementer sites in West Hampshire. And just, Kate, ask you to pose your question, please.
Yes. Thank you. No, that was really helpful. Thank you, Bill and Steve. My question is around specialist commissioning activity and costs, and kind of that variation and the high cost variations, and how that's been handled, because obviously cutting out some of those really high cost ones might be cutting out some of the specialist commissioning activity, and how do we make sure that in reality those patients are looked after, even if they require activity that goes through specialist commissioning at a higher cost?
Good question. In the data model that we used, unfortunately those specialist commissioning items were removed from the SAS data. So this is just looking at the commissioned activity in terms of acute from the CCT's point of view, or the PCT at the time. So those aren't taken into account, but like you say, they would have a big impact on the variation between patients, and maybe something that the model would need to take into account of with commissioning across specialisms.
Yeah, I mean, if we're thinking about a capitated budget for a population and we cut out a significant proportion of the high cost activity, it automatically breaks up those pathways and breaks up that the intention of trying to look at somebody from a whole point of view.
It does, but the problem with it is that it's the low numbers, and that's what we were talking about in terms of what Bill mentioned, is because of you're looking at really low numbers, it distorts everything significantly because of that. So you've got to be careful about not actually incorporating things which are very high cost, which it tends to be, and very low numbers. You've also got to take into account the fact that a lot of the specialist stuff isn't actually built into the long-term conditions anyway. Yes, we need to look at that, but I think in reality it's such small numbers within the long-term conditions itself, it would actually just distort the problem.
But from a long-term point of view, in a tariff development, if we can get more numbers through, would the intention be to try and bring some of that stuff in? Because clearly some of the specialist commissioning activity, especially around cardiac and things, have quite a lot to do with long-term conditions. Some of them do, some of them don't.
Yeah.
But if we're looking at the holistic management of a patient and that's what they require, should it be built into that model?
I think you're right. I think in terms of some of them, yes, you're definitely right. I mean, as you say, the cardiac elements would be a significant impact on that. Obviously, you'd need to get an agreement from them to get the information, because you can't come and get it. But you're right, there are certain things which they are doing which would have a significant impact on the tariff. And yes, they are reasonable numbers to actually not distort it massively. But essentially, I suppose when we end up getting all the specialists back, then it'll all be green again anyway. But hey ho.
Yeah, I'm struggling with, if a patient needs activity that is high cost, but they are under a long-term, well, they are under a tariff-based system like this, should that not all be built in? So if they break their hip because they fell, because they have a long-term condition, that's one of the risks. Should it not all be built in to actually really enable a provider to look after every element of that patient's needs? That's what I'm struggling with at the moment.
You don't, well, and that's the whole point about all of this, is you need to be very very clear on what's actually within that pot of money or that little package of care and what isn't, because it don't matter how much you actually include, there's always going to be things outside it. So it's how you manage the parameters and how you manage the borders of that funding will obviously be the issue which you need to take up with the commissioner and the provider, because you'd have to actually make sure that whatever you identify as in that tariff stays within that tariff, and anything outside it obviously is separate. And I don't think you're ever going to get away from that. there's always going to be things which are going to be outside of the long-term condition tariff. But as you say, the more you can get in, the better off. You're going to have a better chance of actually having a better understanding of how the tariff works and how you actually manage those patients.
Because we're trying to look at drug costs and prescribing costs and equipment, which are two quite key elements of care for these patients, which tend to be at the moment outside of the data that we're collecting, but actually will probably have quite a significant impact on the final cost.
I mean, we have got prescribing costs in there. The thing we haven't got is obviously the high-cost drugs which relate to the acute sector, partly because a lot of those aren't within the SUF data itself. They tend to keep those separately and actually provide that information in a different way, so we need to find a way of actually building those in. The problem with some of those is that they're not brilliant at actually identifying the individual patients and also not identifying the individual drugs themselves. So that's still a big piece of work which still needs to be done around the acute sector, because they're not the best in the world in actually doing their drugs. I would say we have a significant problem with the fact that Southend only identifies what they call bulk drugs and don't actually identify it down to who's actually been receiving those drugs, because they send them down to the clinics and then work out exactly what's been used and what hasn't been used, but that's just one from the other rather than actually identifying the individual patients. So work still needs to be done around that area.
Okay.
So I think it sounds like we're going to have a good discussion on the 18th then, Steve, because we'll drill down a bit further into this detail when the EI sites all come together. Okay. So thank you, Kate. And if I can just ask Lisa to come in, although I think we might have asked and half answered your question already. Sorry, Lisa, but if you want to push Steve a bit harder, you have my support to do that.
I think we've certainly touched on that. I'm obviously coming. I'm in the same room as Kate, by the way. It really was just a question around some of the take forward around calculating the high cost drugs and equipment that Kate mentioned also. So if we're not going to do it in this way, there needs to be some recognition of it. I'm really concerned about that gets left out. I completely understand the reason why it was taken out, to avoid the highs and low swings, but particularly as finances get squeezed, not having full sight, even if it's calculated separately and overlaid or something, means that we're not getting a clear picture as commissioners, and nor are patients for that matter, in what their personal care is costing. Yeah,
I think one thing I would say is this is obviously a step from Southend, and obviously if you can expand it across the whole of England and actually get all the data in there, then you're getting away from the realms of such small numbers, because obviously we're only looking at Southend's population. So when you're looking at specialist commissioning and high-cost drugs and excluded devices, what you need to do is really expand it as much as you possibly can into other areas, so you can actually get a bigger population numbers. Then you could actually do it, and it wouldn't distort it as much as it would do if you just did it with Southend.
Sure.
So I think that's a bigger step which we need to look at and need to have discussions on an EIS basis or even wider than that. But that's an NHS thing which we need to probably do and actually apply it to the whole of England, which would actually then give us a better view on how that would actually impact on the long-term condition tariff.
Okay. Yeah, thanks very much. It was a very clear presentation. Thanks.
Thanks.
Brilliant. And it might well be Yvonne, I don't know if we can unmute Yvonne, but maybe bring Yvonne in here and just his thoughts. And obviously, Steve, you'll know Yvonne of old, but just talked about how Castle Point and Rochford might be, a way of working together. Yvonne, have you got any thoughts?
Well, I think that there certainly is around some of the work around the longer-term conditions, and we're at the moment looking at the way in which we deliver services around localities and locality hubs. So alongside that will be some of the funding that goes alongside the patient. So absolutely, you know, it's gone so far since we first started such a long time ago. And we share bills, so that's always helpful. So yeah, so absolutely, would be really keen to do that, particularly with some of our LTC work.
And the other person, just to bring in, and I'll leave it whether you want to join in or not, but I've been certainly having some conversations with Aylesbury Vale around this particular issue, particularly Lisa's comments resonated in my mind with my conversation with Aylesbury Vale. So, Julie, if you want to make a comment, maybe just let Sandra know as the host, or put your hand up and add into it. But it feels to me like there's probably a little group of us that we need to just bring together to look at some of these exclusions, particularly around medicines optimization, high-cost drugs, etc., and just really work together on them. So I think if people are interested in that, just let us know. The last question I think we've got is from Susie, who's one of my team and in the room here with us.
Clearly addressed to Bill, really, was around when you're looking at the long-term conditions and the number of long-term conditions they've got, is there a kind of a group, is there a pattern in what goes on with what occurs with what? Because we are being asked across different patches around, you know, are there groups of long-term conditions that occur together?
Not something I looked at within the model, but that would be embedded within the data model that I've used. So that could be something that I could generate off the back of that.
I'd be really interested in having a look at that, because lots of sites are saying to us, you know, around, you know, what does occur together? Is there some kind of pattern? So yeah, I'd really like to have a look at that with you, Bill.
Yep. Yeah, no, that's fine.
Brilliant, Yvonne. Okay, brilliant. Well, that's been a really, really helpful discussion, and I think we've started to unpick and prioritise some areas to work on. Oh, sorry, Jamie, who's also one of my team, has got a couple of technical questions. So be ready, Steve. But if we could just unmute Jamie.
For Bill, I guess. I'm thinking, I mean, I looked at one of your graphs that have got all the lines on it, and there seemed to be that a lot of those are overlapping. So I wonder whether you'd get around some of your small numbers if you combine some of the conditions together. And do you actually need the 77, or could you just have the numbers of long-term conditions, just have the 7?
That was the initial starting point that we looked at, so just looking at modelling based on the number of long-term conditions, which would obviously significantly reduce the number of different tariff levels that you would have. What we were concerned with was that a patient with the particular presence of one condition could cost significantly different to the presence of another condition. Yeah. And that is apparent in the chart, but like you say, you can see that overlap in the sort of the bandings or the layers of patients across the different conditions. There may be some scope to merge some of them, particularly where the conditions are sort of almost interrelated, or they are common, as the previous question was around what sort of common conditions occur together. So that could be something that we could look to do, particularly to avoid that small numbers issue. I think probably the easier way to avoid the small numbers issue, though, would be to scale up the model to encounter a wider geographical patch. So,
yeah, I guess my only concern about the wider geographical patch is if you start having if you're delivering services in different ways in those different geographic patch, that might have a cost implication as well, which may then introduce some more cost variation. I don't know.
Well, one way you can get around that, Jamie, is to actually have a generic way of actually collecting the numbers and the costs, because the large proportion of it is going to be on a national basis anyway.
Yeah.
There aren't that many which are not. Is when you start getting down to the likes of community and potentially mental health and some of the social care elements. That's when you're probably getting some level of variation. But one way of dealing with that is to actually try and come up with a generic way of actually collecting that data and actually analysing that data to see if there are significant differences in how that's delivered. and then taking that into account. So, so there are ways of doing it, but the majority of the data nowadays tends to be on a national basis anyway. So hopefully there won't be large variations in that. And obviously, the more we do around national data sets, the better it will become.
Yeah, yeah. The other thought I had was that it looked like some of the conditions, it might be reaching a maximum level at about 4 long-term conditions. So once you get to 5, 6, 7, perhaps there's not much change in the cost. So another way to get around some of the small issues, small numbers in terms of many long-term conditions, might be to combine some of those latter groups.
A variation in the maximum depending on the condition. Yeah.
Yep.
Would be one option.
Yeah. Okay, I think that's all, Bev.
So thank you, Jamie. That's brilliant and well responded to, Steve. So thank you very much. I think that's been a really interesting conversation, which is really only the start of many of our conversations. Just really to Bill and to Steve, just to say that I'll come back to you in a second to put forward, you know, what are the couple of things that people could go away and do this afternoon? You know, what are the priority areas that people should be thinking about who are already along this path of understanding capitated budgets? And just to turn around to our audience and say thank you very much for joining us. It's been a really good use of an hour. I hope you agree with that. We will send you the slides and the recording over the next day or so, but we'll be very much interested in hearing some of your discussions and conversations locally to see how we can support you across the team to make progress. And we will be publishing work from all of our early implementer sites, including Southend's work. So we'll make sure you stay connected with that as it comes out in real time. And hopefully, if you're not already registered for the 4th of February, then I would ask that you do that as soon as possible, or just drop me an email and let me know, and we can make sure that we have room for you. So finally, back to Steve and to Bill. What 1 point each, or a couple of points each? What are the priorities, do you think, for us all?
I mean, I think for me, the priority really is to make sure that if you're going to go down this route, that you have got all your sign-ups to sharing your data with everybody you think you need to get a sign-up from. So there is a significant amount of work you need to actually get them on board and keep them on board.
Yeah, I think I'd reiterate that and just say gathering the data is probably the most crucial element of the whole thing. Being aware of what data is available and how you can link that data together to build a baseline data set that you can model around really opens the doors to what you can do. Once you get that data in one place, there's no limit to how you can then model that in various different ways. But getting that data in one place is really the key part, as Steve says.
And I guess that's about getting people to buy into the principles of what you're trying to do rather than just, you know, releasing data. It's about what the ultimate ambition is for the programme and keeping that buy-in. So that's brilliant. Thank you very much. Brilliant presentation. I will just at this point call the WebEx to a close, and we will make sure the information gets out to you, and wish you a good afternoon, and thank you for joining us.